My name is Rich Fisher. I'm the programs chair for the Academy, and it's my pleasure to introduce our next speaker. Dr. Reed Winnick is a graduate of NYU College of Dentistry. He has had extensive experience in general dentistry, the oral systemic link, as well as in TMJ, craniofacial disorders, and he's a founder and president of Dentistry for Health in New York City. Dr. Winnick is past co-founder and director of the Facial Pain TMJ Clinic at the New York Eye and Ear Infirmary. In addition, Dr. Winnick is the co-founder of Herbal Difference Organic Products for Treatment of Periodontal Wellness. I've had the pleasure of having Dr. Winnick as a friend for some years now, and had actually a pleasure of visiting him in his office in New York a few years ago. But Dr. Winnick has really introduced some very innovative ideas, concepts, and treatments in the management and treatment of periodontal patients, and so it's a great pleasure to introduce him to the Academy. As he's going to do a session now, and then a little break, and then do a second session. So again, Dr. Reed Winnick, welcome.
Thank you. Thank you. Well, I want to thank all of you for coming out today to hear this presentation. I have to just do some order of business first. This is my AGD disclaimer. Basically, it says I do and I do not have any financial interest, but I do have some in the products that I may talk about, with some companies offering grant monies or that I basically own, okay, or am partner of. So when that happens, I will discuss that with you. One thing I want to just bring up, just with the title of our office. Years ago, we were we were always holistic doctors. Today, we're considering ourselves health and wellness dentists. And before I really go on, I really want to just also thank the Dr. Fisher and the Academy for inviting me here to speak to you. You know, I've been a member here for 15 years. I've made a lot of friends from the Academy. Some of them were actually mentors of mine. But one thing always stuck out in my head, that the Academy members here were so bright and innovative, of most of the groups I belong to. So I'm really honored to be up here to discuss Dentistry for Health. So the lecture we're doing today is in two parts. The first part will be discussing the oral systemic link. And I'm sure most of you are familiar with those words. I'm sure most of you will be familiar with the information that I give you today. And I'm sure if we can go home with 1 or 2 pearls on Monday morning, as they say, we'll all be very happy. The second part of the seminar will be what we've created in our practice in New York City, and what I see as the future model of dentistry. Now, the history of the oral systemic link goes back to Charles Mayo, Weston Price, who developed standard process, Royal Lee, Weston Price, who was a big researcher in dental disease, Royal Lee from standard process, Perry Radcliffe, who developed some perio products that decrease sulfur, and Donna Shalil. Charles Mayo noted over 90 years ago that people who keep their teeth live an average of 10 years longer than people who do not. This is a picture of Weston Price, considered the father of preventive dentistry. Then, of course, Royal Lee, who developed standard process and looked at the systemic causes of dental caries. And then the former Surgeon General from 2000, who said that the terms oral health and general health should not be interpreted as separate entities. Oral health is integral to general health. This report provides important reminders that oral health means more than healthy teeth, and that you cannot be healthy without oral health. And of course, you have Thomas Rao when asked which clinic he would prefer to keep in his wellness center. And he said, if I needed to remove either the medical or dental component of my clinic, I would keep the dental because chronic problems will not resolve without biological dental care. So today we're going to be discussing two different systemic problems. We're discussing cardiovascular disease and diabetes as related to periodontal disease. Most of you are aware probably of this type of schematic where you have on the left side, you have the bacterial challenge. And then if you go down, you've got the host immune inflammatory response. Now with the bacterial challenge, you have the antigens get released. But the important part to look at over here is that it's not just the bacteria, but it's also the host immune response to the bacteria that's really important. And then you have a cascading of events which release cytokines and prostaglandins, which affect connective tissue and bone metabolism, and then we start to seeing clinical signs of periodontal disease. The important point also is that you've got this box on the bottom that is separate, and that's your outside environmental risk factors and genetic risk factors. So we know that if you have a genetic predisposition to inflammation, then that would affect your degree of getting periodontal disease. We know that, let's say, if you smoke, then you're more at risk of having periodontal disease. So there's always these outside risks that need to be monitored and looked at also. And as we said before, the bacteria are necessary but not sufficient, because there's always sometimes bacteria in people, but why aren't they showing a disease? I think it has to do with also the amount of time that the bacteria is present. I think the longer the bacteria is present and it's not dealt with properly by the body or with the oral home care, then we will see the disease progression increasing. The important point is that this is very similar to other inflammatory diseases where variability in host response is a major determinant of clinical disease. So periodontitis is an inflammatory disease, but it's not just about the bugs. But also realize that periodontitis is a mucosal disease. So what that refers to is that you have to realize that if you had no teeth in your mouth, then you had a closed skin surface, there's less chance for the bacteria to infiltrate into the body through the bloodstream. It's only when you have, for example, if you go to a hospital and they put a catheter in you because you're getting an IV for long-term treatment, every 2 or 3 days they have to remove the catheter and change it, because the moment you pierce through the skin, you're opening up the skin to a bacterial invasion. If there's no piercing of the skin has a very strong barrier. Well, an edentulous ridge is a very strong barrier. So think of your teeth as 30 different or 32 different splinters or pieces of wood passing through the mucosa and opening up the barrier to the rest of your system. That's what makes the oral cavity different than any other part of the mouth. Okay, so periodontitis and peri-implantitis they're inflammatory mucosal diseases. I'm sure this is research that you're familiar with. We asked Boyd Haley, do the bacteria in our teeth, in our mouth, and our gums, does it go into the teeth, into the dentin? Do toxin-producing microbes reside within the dental tubules? And he looked back at some studies from 1997, and the findings supported by laboratory studies have indicated that periodontal pathogens may penetrate connective tissue epithelium and epithelial cells. And here's a photomicrograph of the bacteria actually getting into the microtubules. And another study looked at the bacterial invasion in root cementum and radiculodentin of periodontally diseased teeth in humans, and it's as a reservoir of periodontic bacteria. And again, periodontal bacterial growth was detected in 87% of the periodontally diseased teeth. So do bacteria reside within dental tubules of vital but periodontal diseased teeth? Yes. Are these teeth infected? Yes. Does the cementum provide an impenetrable barrier that prevents the entry of bacteria into the dental tubules of vital teeth? No. So we have to keep all this in mind when we're treating our patients from a periodontal point of view, from the systemics, because if the bacteria are residing within the teeth, we have to figure out a way to deal with that also. Okay, so the perio heart disease connection. Now, when you start looking at the studies, I would say every month or so they're coming out with more studies. And I remember having conversations with one of my hygienists where it was like 10 years ago, it was like, oh, well, there's no, the proof isn't there that gum disease causes heart disease. And I'm like, yeah, but it's coming. And the reality is every time we see another report, it's getting closer and closer. And I think it's going to come out that the research is going to show that the chronic inflammation that we see with gum disease is a real problem for most of the systemic problems that infect the inflammatory part of diseases in the body. And we need to realize this. And we also need to align ourselves with our patients and our community and educate them that we are at the forefront of their health. So overall, there were 28 of the 36 studies done showing that gum disease is an independent risk factor of heart disease or stroke. Now, you can look at the degree of risk and you can say, well, it's low to moderate. Well, then so what? But when they look at these studies as it impacts a society, so the morbidity rate is really high because a heart attack causes 50% of the time death. So even though the degree of risk is low, it still has a high morbidity, so it's still clinically significant. The important thing to look at also is the degree of getting a stroke is higher than that of a heart attack. How does this relate to our patients with gum disease? Basically, the more teeth that are affected by periodontal disease, the higher the risk. And we all know what happens. We set up a bacteremia gets set up. It goes the bacteria and the toxins go into the bloodstream and start this inflammatory cascade. And they did a study, and they found out that the incidence of a bacteremia by doing an extraction is 80%. When they put the patient on amoxicillin, it was 56%, and then they had toothbrushing alone will cause a bacteremia of 32% of the time. So you even get a bacteremia with antibiotic prophylaxis, and that's probably why they've changed the guidelines for patients with heart murmurs. And then they did a study and they found that by chewing gum, you can get a release of the endotoxins also. I put a lot of these slides in here because this is usually a longer seminar, and I wanted you to have them in your notes. But the biggest, something of importance is that 6% of the subjects that had an endotoxemia before chewing versus 24% after chewing. But after chewing, only 12% of the perinaturally healthy subjects had an endotoxemia versus 40% of the severe perio patients. So we know that chewing may induce systemic endotoxins, and by having a periodontal disease, that makes it worse. So the oral cavity is a reservoir for endotoxins. So this is an important slide. This shows the lumen of a blood vessel. It shows the formation of the foam cells. It shows the endothelial cells, which we'll discuss at the second part of our lecture. But basically what happens is, and I'll just take you through this quickly, the initial stage of the atheroma formation are inflammatory in nature. The initiation and progression of the atheroma formation involves damage to the vascular endothelium from bacteria, viral, chemical, shear forces, inflammation, so you get adherence and penetration of monocytes into the vessel wall. You get production of chemotactic and pro-inflammatory cytokines by monocytes and macrophages. Monocytes become engorged with circulating LDLs to form large foam cells. Chemotactic and pro-inflammatory factors stimulate smooth muscle cell proliferation. End result is formation of the atheroma, thickening of vessel wall, narrowing of vessel lumen. Pro-inflammatory cytokines can result in rupture of fibrous cap over the atheroma with formation of thromboembolus. Hematogenous spread of bacteria and bacterial products from other sites may stimulate similar cascade of events or worsening existing conditions. Periodontitis results in increased systemic bacterial endotoxin levels following normal chewing. Oral periodontal pathogens have been found in carotid atheromas. So I think the evidence is there that we have a big effect on our patients' oral health. And wouldn't it be great, as dentists, we can predict our patients' future heart disease rate in 10 years and help them prevent getting a heart attack even before they have signs and symptoms. So here's a study that was done, and it showed that 44% of the atheromas had at least one periopathogen, 59% of these had greater than one. So we have the direct effect, which we just spoke about, and there's also the indirect effect, where you see serum fibrinogen and C-reactive protein levels are higher in patients with periodontitis. You get elevated fibrinogen C-reactive proteins are risk factors for heart disease and strokes. And cardiovascular risk factors, IL-6, fibrinogen C-reactive protein may be intermediate variables linking gum disease to increased CVD risks. And basically here it is in a schematic. That's the direct and the indirect effects. Now, can we affect our patients? They've looked at can periodontal treatment decrease serum inflammatory markers, and they've done some studies, and they noted that there was a significant reduction in serum CRP and IL-6 levels at 6 months after treating patients with scaling and root planing. Now, I want you to understand that, you know, we belong to this academy, and we've always had the hat that we're mercury-free dentists, we're holistic dentists. Wouldn't it be great that if you met another doctor, a naturopath or a chiropractor, and they found out that you were a holistic dentist, and instead of saying to you, oh, when I have my mercury, when I need someone to be detoxed of mercury, I'll send them over. Well, how about if they said to you, you know what, I have a patient who needs your help because you understand the oral systemic connection and how to solve it, and they don't just look at us as the group that removes mercury safely. So when you look at the phases of research, there's these three different phases. There's the correlation, the causal factor, and the treating para disease. I bring this up only just to show you what's out there. This is at Yahoo News. So the American Heart Association came out with this in 2005, and it goes on and on. You have insurance companies recognizing it. The American Diabetic Association recognizes it. Who remembers Reader's Digest, what, like 10, 15 years ago, when dentists were like the scourge of the South? And they had that scathing article against dentistry. Now Reader's Digest is saying how dentists can save your life. It appears in WebMD. Colgate has a big promotion. Here's Cigna, the insurance companies, the ADA, Aetna. They all are talking about how dentists play a vital role in treating the health of our patients. And then in the news you get CRP gains notice as key marker of cardiovascular health. And it goes on saying how that could be affected by gum disease. And there's just more studies showing how periodontal disease reduces CRP. I found this study a few months ago, and it was kind of interesting. Let me just read this one to you. It says a multiplex immunoassay demonstrates reductions in gingival crevicular fluid cytokines following initial periodontal therapy. They go on to say that our prediction is that one of the criteria to denote the end point of periotherapy will be GCF and salivary tests for levels of periodontal pathogens and inflammatory mediators. The relevance of this research is that in the near future, successful treatment outcomes will be measured not only by clinical improvement, but also by measuring the reduction of inflammatory mediators and bacterial levels as well. So the question I put out to the audience today, how many people are doing something in their office when a patient comes in for gum disease? Are they measuring the amount of bacteria in the sulcus? How do you know when a patient comes in the level of infection that they have when you start treatment? How do you know when you're finished with treatment? How do you know a patient who comes in who has a mouth full of wiggling teeth and inflamed gums, but they're pristine clean? How do you know that it's not a nutritional problem or a bacterial problem? What this researcher didn't know back in 2009 is that we have those tests available to us now. There's a big push with the cardiologists. For the first time, the American Journal of Cardiology came out with a consensus report, and they sent it to every cardiologist in the country saying that periodontal disease is a problem that needs to be looked at when you are evaluating your patients, and you need to team up with a dentist to treat your patient's gum disease while you're treating their heart disease. If you want a copy of this, I have it on my website. You can get that over there. But another point which we'll be discussing later on this afternoon is you want to be able to single yourself out as the dentist to be seen to treat these patients. Because just going to any old dentist isn't going to do the same thing for your patients as you potentially can do. Just like the dentist down the block doesn't understand the safety of removing mercury. Well, they don't really understand the intricacies of treating gum disease as a true chronic infection. So we're also going to look at gum disease and diabetes. Again, probably a subject you're all very well versed in. Diabetes is a disease of metabolic dysregulation. of glucose, protein, and fat metabolism. You can see the long-term complications, retinopathy, macrovascular disease, and for us, wound healing. Diabetes is becoming or it probably is by now, an epidemic. And the amount of diabetics is growing every year. Basically what happens, you've got food coming, you're eating some food, blood glucose goes up, increases insulin secretion, then you get tissue utilization of the glucose, and then the blood glucose levels go down. There are different categories of diabetics. Let's just mention them for now. Diabetes type 1. You've got diabetes type 2, which is probably the most prevalent. Gestational diabetes, impaired glucose tolerance, impaired fasting glucose. Those are your pre-diabetics. The American Diabetic Association about 6 months ago came out with a statement saying that they feel that gingivitis is the first sign of pre-diabetes. So what that tells me is, and what I tell my patients is, we have the ability to look in their mouth and predict their future wellness or unwellness based on what we see in terms of the breakdown of their mouth. If they're getting cavities, if they're getting gum disease or other infections, you know those are the early signs of some long-standing chronic inflammatory problem that may hit them later on in life. You have maturity onset diabetes of the young. There's also a type 3 diabetes, which is, they're not sure if this is going to be what they're going to be calling it, but it's a condition in which the brain insulin levels are low. They think it might be linked to development of Alzheimer's disease. There's 3 ways to diagnose diabetes. You can do a fasting plasma glucose. You can most patients who are diabetics, if you say to them, what's your HbA1c, that's pretty much their 3-month average of what their blood levels are. And they would know it. What's normal is below 6%. And if it's above 8%, that's when intervention needs to be done. Now, we offer this test in our office, along with C-reactive protein and some other tests that we do. We don't diagnose diabetes. We're not allowed to. We're dentists. But we can refer them to a doctor for follow-up. Also, this is put on so that you realize that they're changing the category of how they look at the blood glucose levels. It's a new method. Instead of the HbA1c, now they have a chart and they're looking at the EAG, estimated average glucose, which is the same as the A1c. They're just calling it a different name and using a different value system. After doing this research, you realize that diabetes is a very serious disorder. When you talk about someone getting blind or losing a limb or having all these sores and losing toes, you realize that this is something that needs to be dealt with. Also, it's important to note that the important part with diabetics is the prevention of diabetic complications is directly related to their glycemic control. And you'll find that glycemic control is a main factor with your patients when you are treating them periodontally and when you're also putting in implants. It's a two-way street. We know that diabetes causes gum disease. We know gum disease causes diabetes. And these are the changes we see with our patients who have diabetes: enlarged tissues, increased rates of bone and attachment loss, numerous mobile teeth, abscesses, often multiple. So if a patient comes into your office and they have multiple periabscesses, that should be like a red flag. This patient needs to be tested to see if they are a diabetic. Or if they come to your office, let's say you do some kind of surgery on them, and they have granulation tissue and you remove it, then they come back a week or 10 days later and the granulation tissue is back, you would want to biopsy that granulation tissue to make sure that it's not some kind of cancer. And if it's not, then you know they possibly have diabetes or some other systemic problem. Okay, so let's talk about some of the evidence about this circle. Is diabetes associated with increased prevalence of periodontitis? Does the level of glycemic control affect the degree of periodontal destruction? So we have some studies here, and what the studies are showing is that if the patient is poorly controlled, then they're more likely to have periodontitis. And this is what this is showing over here. So glycemic control is very important. The patient must be told that good diabetes control will give them good periodontal health. The important part to realize also is that patients who are diabetic, what happens is they affect the collagen. You know, we have collagen in our blood, and we're supposed to have a certain amount, but with diabetes, the collagen level can go up, and then that will cause more attachment loss. So let's look at the effect of periodontitis on the metabolic state and the effect of periodontal therapy on glycemic control. Again, it shows that this study shows that type 2 diabetic subjects with severe perio had increased risk of worsening glycemic control over 2 years compared to diabetic subjects without gum disease. Why? So this was a small study of 9 people, and it showed that it actually showed that glycemic control was important, but that was a very small study they did back in the 60s. So they did another study with 113 subjects, and they showed that scaling and root planing with doxycycline, which inhibits collagenase, but that was done back then when that was the standard of care for treatment, had an impact in decreasing the HbA1c levels and improving glycemic control. Many people looking at this and saying, well, you need to do scaling root planing and doxycycline, and that is what is going to help these patients. But to do the study accurately, you would need another bar that just had doxycycline, and then you would see if the doxycycline had a major benefit. Now, these are studies, and these are how these practitioners did the treatment. In our wellness center, we have a whole different philosophy around what we do for our patients, and we can discuss that later on. So not all these studies agree, and you can go back and do a web search, and some studies show periodontal treatment improves periodontal condition with minimal impact on glycemic control. But overall, these studies had small subjects, and they weren't done 100% adequately. But if you look on the large picture, the studies will show you that gum treatment does affect glycemic control. And how can periodontal disease affect diabetes? By changing the way the body uses insulin. Inflammation increases insulin resistance and makes blood sugar harder to control. Insulin resistance is a major cause of type 2 diabetes. The body cannot use insulin that is being made in the pancreas, so the blood sugar is not controlled. So what they've done is they've actually said, well, let's forget the mouth. Let's look at what happens when someone has an infection. I think they had lung infections with this study. And what they found was infection increases insulin resistance and alters glycemic control. But what they also found was how the insulin resistance went up with the acute infection, not the oral infection, some other infection. But they also found after the infection was gone, there was still a 1 to 3 month post-recovery rate where the insulin resistance was still raised. So this tells us that it's not just localized to the mouth and that infections do affect glycemic control. So let's talk about obesity. Obesity is the #1 risk factor for type 2 diabetes. Why? Obesity increases insulin resistance like inflammation does. The adipocytes, the fat cells, they produce pro-inflammatory cytokines like TNF-alpha, which directly change the insulin receptor and prevents insulin from working. Very similar to gum disease. It also causes an increase in serum levels of inflammatory mediators like TNF-alpha, which causes insulin resistance, just like obesity. And here you can see a schematic of that. So let's just talk briefly about the management of diabetics. Okay. So do they respond to non-surgical, surgical periodontal therapy? Well, they will if they're controlled. Now, when we talk about diabetics as a whole, this is the average. Not every diabetic has gum disease. So realize that it's really, it could be, let's say, 35% of the diabetics show up with gum disease. So don't think every patient walking to your office who's a diabetic will have gum disease, and not every person who has periodontal disease will end up with diabetes. In regards to implants, if the patient is under control, then with their glycemic levels, then the implant should work. Now, there aren't many studies with implants. You would like to see more. They just haven't been done yet. If you look at this study, though, it shows that there was a slight increase in the failure rate of patients who had type 2 diabetes. And if you can look at it clinically, you say, if you look at it just by the study, you say, well, it's a significant amount. But again, we have to look at things clinically. So if you tell a patient, well, your implant is, if you have good glycemic control, your implant has a 92% success rate. Well, I don't think there's any dentist here who would say, well, that's not a high enough success rate. They'll go with, and they'll say, okay, for the implant. I mean, you know, do all crowns fail? Do all crowns, are they all successful? Do all fillings last forever? So the reality is the research they have presently says as long as your patient has good glycemic control, they should be fine candidates for implants. I'm not discussing the type of implants, I'm just discussing implants. So then you can go through a medical history and you can ask them the signs and symptoms and run some lab tests, or you can send them back to your doctor, or you can do some in-office finger sticks for fasting or non-fasting glucose and HbA1c levels. And in general, with the management of diabetics, depending on your practice, depending on the doctors you see, either diet and exercise, oral agents, and insulins would be part of their program. The key thing that we need to be aware of and should be ready in our office is if our patients become hypoglycemic, because then they can faint and you can have a problem, and you want to be prepared for that. So many times when you have a patient who comes to the office, you might want to have them bring their own glucometer so they can be tested in the office with their own machine, and they'll know exactly what level they're at. Getting a glucometer in your office there's a lot of governmental regulation, so you may not want to do that. But you should have some kind of juice or sugar or some kind of cake, gel, or frosting in the office just in case the patient has a hypoglycemic reaction. Then you have your standard diagnostic, your medical history that you go through with your patients. Ask them the A1C levels. You can see the recommendations again. You want them to be around below 7%. Discuss if they're being treated, when to treat them. If their glycemic control is poor, then you just have to get a physician's consult. Back then when they did this study, they put them on doxycycline. Again, the important factor here is compliance by the patient, and that will give you the control of the periodontal problem. One of the reasons why I speak at these meetings is to educate the dentist that, and this group is probably on the top of the list of educating patients and asking patients about their, dentists asking patients about their history of diabetes. So they did a study, a mail survey was sent out to 105 GPs and 103 periodontists, and they asked about the managing of diabetic patients in the dental office. And 44% of the GPs responded that they asked their patients what kind of diabetes they have. The periodontists were higher. But you can see when it talks about communicating with the patient's physician or that do they monitor the glucose levels, it was very low. And I think if we're going to be responsible for our patients, we should have this information at hand. So as I discussed earlier, the key is managing the inflammation. They did a study and they saw that the extraction of all teeth would decrease systemic inflammatory and thrombotic markers. After 12 weeks, the serum CRP, fibrinogen, plasminogen, activated inhibitor 1, white cell count, and platelet count all decreased. And that goes back to the whole inflammatory scheme, the whole mucosal disease scheme. So is full extraction needed? Well, my theory is full extraction is not needed. However, if the patient goes untreated and unchecked and uncared for, the body will take its own self in its own hands and will extract the teeth on their own. I think the body is an amazing mechanism, and why would the body attack itself and lose the bone? Because whoever created us knows better. They know that if the inflammation from the bacteria is left unchecked, then they need to get rid of the cause of the problem that can cause all these systemic illnesses. So the body will then lose bone, and you lose your teeth, and you get rid of the problem. Recent studies have shown that periodontal treatment decreases per member per month costs with populations having DM, CAD, and CVD. That was by the insurance companies. So it's becoming mainstream. It's becoming normal, everyday knowledge that your dentist is the key person to see for overall wellness for our patients. And I think that one of the missions of this academy is overall wellness. And I think that as an academy, we should get together and say, it's not just about mercury. Let's become the driving force. Let's become the vehicle that educates the public that gum disease is an important situation and that the dentist is the key factor in helping you treat your patients' inflammatory problems. I don't know if you heard about it, like 3 months ago, a woman was pregnant she had a stillborn, and she reported having inflamed gums during her pregnancy. But she wanted, so the baby was no longer alive. She was distraught, but she wanted to know what caused the baby to pass when it was born. So they went and they did a culture on the baby, and they found it had a specific bacteria, a bacteria not normally found in babies. They went back to the patient's, the mother's mouth, and they isolated the same exact bacteria in the baby that caused the baby to be a stillborn. So we have the ability and the training and the desire as an academy to really make a difference. However, I think we need to start looking at what we do differently so that we can distinguish ourselves from the other academies who don't understand wellness as well as we do. Which is why I created Dentistry for Health, and not just I'm a holistic dentist. It's just more studies. Okay. After the break, we'll discuss pretty much what I consider the future dentistry, the future model of dentistry, the model that we created in our office, and the systems that we have put in place.